So this is another patient journey, and I think we want to talk about Taruna's family, Alya, the path to n-Lorem, the path to Liz and Rush. Alya's a PAX1 pioneer patient, so I think there's a lot we can talk about there. I've realized that Taruna's a person who is into like facts and is logical, and we're going to talk about things that are clinically relevant. And the realities of this entire thing.
How did you realize that?
By talking to you, I just knew it. So my job is to sort of take us through that path, and I think I want to start with you, Taruna. So just talk about, Alya's your second born.
Yes.
So Alya being born, and then you realize, okay, there's something that we need to deal with here.
So when she was born, we didn't know of anything. I mean, I had a lot of genetic testing when I was pregnant. Everything was normal, and then when she was
normal genetic testing.
Well, I mean, the typical like microarray, like not a full exome or anything, but enough testing to test for a lot of conditions, and everything was normal. And then when she was 5 weeks old, she started having seizures. I mean, she probably had some of them before, but these were uncontrolled, and she was in status basically. So we were rushed to the emergency room at Cornell, and a 5-week-old in status, that's a pretty bad start.
Terrifying.
That's not, you didn't start like a Ferrari basically. So that's terrifying. We didn't know what it was, but because we had already run all of these, we'd done a microarray and done karyotype and all this analysis, I think they didn't go straight to sort of the genetic testing on the spot. They were able to control the seizures mostly with medications. So there was a lot of Band-Aids, put on sort of the symptoms that she showed. And she was really delayed in everything. I mean, smile late, walk late, talk late, like thousands of hours of physical therapy, speech therapy, OT, everything. And she was very, very delayed. And so by the time she was 2, it was sort of like, this isn't sort of something that's going to resolve. Like something's wrong here. And so she had a full exome test. And so her disease is actually pretty specific in the sense that it's a single point mutation at a point in the PAX1 gene. So it cannot be diagnosed through a microarray and all these other tests. So it was a relatively new disease. It had only been sort of classified as pathogenic maybe 2 years, like the year before she was born, essentially. Wow. Yeah, so it was a very new disease at the time. So they did a full exome test, and she was diagnosed. And
can I ask you how you got to that point? So for the first 2 years, you're thinking, well, she's delayed, but maybe that's not a big deal. Maybe you're thinking it might be autism or something. I don't know.
We were just hopeful that it would go away, I guess, right? Like, I mean, we're hopeful with the therapies, and babies do so little, like, so you can always hope that whatever, she's gonna have a few words at some point or whatever. But by 2, she was, she had her seizures were still, I mean, she didn't have that many seizures, but she had a complicated condition in neurology. It's called electrical status epilepticus of sleep, which is like, it can be really debilitating. And the kids don't have seizures, but they have so many spikes at night that they can't learn anything. So it was just clear that this wasn't something that was going to resolve as much as you could hope that things will just go back to normal. It was clear that it wasn't. So her neurologist at the time we were at Columbia said, let's do a full exome. And so we did, and we got the results. But there was nothing known really. I mean, there was a few kids that had been diagnosed. I mean, maybe 50 kids had been diagnosed before, but there was nothing known. Globally, I think, yeah. Wow. But there was nothing known, and there's 200 now, so it's still pretty small. But there was, and then they all, while they all have the same mutation, they exhibit a wide range of phenotypes. So, you just have no idea. I mean, some of them can have, 3 words, and Alya has none. So it's sort of very variant in terms of what the kids look like. Mm-hmm. So it was pretty devastating because we get this diagnosis, this piece of paper that your kid has this disease, and nobody knows anything about it, So was there any like also feeling of relief, like, oh, okay, now we know what this is? Then it's like, well, you're told there's nothing that we can do. Was that balanced at all? Or no, I don't think there was that much relief. I mean, sure. I mean, I guess it's not a disease that results in death quickly. So we knew that there wasn't a life expectancy issue. But no, I don't think there was relief. I think there's a lot of devastation and a lot of sadness about what we had lost. That she was never going to be typical.
Yeah. So right. So what you lost was the sort of
the hope that
The hope
she'd
that,
be
yeah,
all
what
right.
you had, what you thought she was going to be.
She wasn't going to go to Harvard, but maybe she'd be independent, and
Yeah.
that was lost even.
Yeah. Okay, so you get this new bit of information, and then do you do, well, obviously you started the PAX1 Foundation, but...
Yes, so then we started digging around, and we realized there was no research, there was nothing going on. I mean, nobody knew anything about the disease in terms of, what is the mechanism of action, like, what causes this disease. And the reason that there was nothing going on is, it's one of the things that, n-Lorem talks about all the time. These kids are just left behind because they're rare, and so at that time, my husband and I decided that, just because Alya is rare, like that doesn't mean she shouldn't have an opportunity. And so we started the PAX1 Foundation, PAX1 Syndrome Research Foundation, the year that she was diagnosed, with the goal of, advancing research towards a treatment for the disease.
So let me ask you about that too. You start the foundation, you could go in one or two ways. One is, hey, let's raise awareness, let's form a community so that we understand, there's something nice about the community. I'm going through this, you're also going through this. But you wanted to start a foundation that was like, we are going after the science of this.
Correct. And that's what I, as you said before, I'm very fact-oriented. Yeah. And that's my husband's, even as Liz will say, even more on that end of the range than me. So I think that's what we'd be good at. We're good at doing things factually, at science, at really quantifying things and figuring out a plan and going for it. And so that's the way that we thought we could contribute best to the community.
So as you said, 50 kids maybe at the time.
Yeah.
So what was your plan? I mean, there really was so little science known about it.
Yeah.
What was the plan?
So we started off, one of the things we did was we started off by hiring a scientific advisory board, and with 4 people. So with 4 people that really had to make decisions. We didn't have 15 people that sort of kind of could give you advice here and there. We were very clear from the beginning that the foundation would be driven by scientists. Mm-hmm. And so that was how we started, and I think that's what has driven us from the beginning.
You found 4 scientists who knew something about this.
Not about PAX1, but about genetic disease.
Yeah.
Because nobody knew anything about PAX1.
Yeah.
And then we also separated like the scientific board from people we'd fund. So the scientific board doesn't get, they might get paid for being on the board, yeah, but they don't get funding from us. So it's a very independent decision-making process. Like every grant we make, the scientific board looks at it and approves it. So we ran it as a business almost, so to speak, right? Like as in, here's a scientific board, this is the science that makes sense, what are we missing, what are the things we need to put together? So we started with cell lines, mouse models, those sorts of things. Then we invested in funding grants in cell biology and structural biology. So we built it in terms of the roadmap that the scientific board put together for solving a disease that nothing was known about, but had been done before for other diseases. Yeah. Just that was the roadmap that we followed.
Yeah, and did you have one eye toward Alya this whole time? Meaning like, hey, we want to fund studies that we know might be applicable to our daughter, or just anything that looked like it would be useful for the community you'd be willing to fund?
But anything applicable for Alya was applicable to the community because they all have the same mutation. Yeah. So, but of course, kids always at the top of my head, right? But, science is slow, and it takes a lot of time, and I was very deeply involved in it. So it was difficult, some of the cells don't culture, and then the mouse never, took a long time to be made, and so it's hard, but. Yes, Alya is always at the top of my mind, but I think the science for Alya is the same as the science for every other kid with a disease. Yeah.
Okay, so that's going on. Meanwhile, your daughter, right? So what are you doing for your daughter? How do you eventually find your way to Liz and Rush?
So n-Lorem started in 2020, and so we learned about n-Lorem, and we were very.
How did you, just Googling around?
We were in this. Being in that rare disease space, it was difficult to not know about n-Lorem.
Good.
I think. So we knew about n-Lorem, and we applied Alya. We met Liz a few years ago. She had already done a lot of work at an institution, not necessarily with n-Lorem, but previously with other diseases, and so she was willing to take us on, and you know, she has a fantastic team, and everybody knows Liz. I mean, she doesn't need an introduction, but and so, you know, like I said, she was willing to take us on, and we were really excited to, and we've been together for a few years now. So
tell me about that. This family coming to you and you deciding to take them on, as Taruna says.
Well, originally Joe Gleason emailed me and told me about Alya and her family and asked me if I would see her because he didn't think she could be seen in California since she didn't live in California, and there's a restriction on treating people outside of California. So it turns out Chicago's a lot closer to New York than California. So I said, sure. I mean, because we had patients at that time with ultra-rare diseases that were flying in to see us from as far as Germany or, you know, or Costa Rica. So that didn't seem that far away. So, you know, we talked and we organized and we set up an appointment. And n-Lorem already had her in their list when I first saw her. I didn't actually have to submit her, so I'm not exactly sure how that happened. You would know, but...
How did that happen?
We were submitted through Joe.
Okay.
But I mean, this was very early on in the process, so it wasn't. I think it was a little different than it is now. Potentially. Yeah.
So yeah, she was one of the early patients. So then we said, well, we don't know how long it's going to take to make this ASO, but we're going to talk to you about like what the biggest problems are, and so we came up with a list of problems that were affecting Alya the most, and we tried to find outcome measures that would fit those, and then we were going to do this natural history study, and the longer the not the longer the better, because that means you're still waiting for the ASO, but the longer from a data standpoint the better, because then we really know what Alya's trajectory is. So we had we were just looking at, we had about 2.7 years of natural history by the time we actually had the ASO developed. And I think it got snagged along the way a couple times. The original plan was to develop an allele-specific ASO, but as the research that was being funded by the PAX1 Foundation grew, and it became clear that perhaps you didn't need to worry about keeping the normal copy of PAX1, you could just knock out all of PAX1 and PAX2 would kind of compensate. Then, you know, that was the direction that the ASO went. So
you said 2.7 years. You're gathering these metrics. What are you gathering?
Well, we have certain things we're getting yearly because they don't change that fast, like the Bailey, which is kind of the standard developmental test that we use for kids whose development is still, you know, their mental age is still below like the 3 or 4-year-old level. And we were collecting adaptive behavior. We were collecting some questionnaires about different aspects. We tried to, one of Alya's problems was chewing, and we tried to develop a chewing measure, but that didn't kind of work out. So there's some things you try because you think it would be nicely targeted to the patient's symptoms, and then it just turns out to not be a measure that's going to work. So it was a group of measures designed to look at really every aspect of problems, and then we were incorporating EEG as a biomarker because although Alya wasn't having very frequent seizures, she had these spikes on her EEG overnight when she was sleeping, and we thought that would be something that we could count to see if the disease in the brain was actually changing.
And you know, as we said, there were 50 other at the time people that we thought had a PAX1 mutation. Were you able to look at these metrics and compare to them, or are you just gathering it in the hopes that one day this will be useful for someone else to look at?
We were gathering this to map Alya because she had a treatment plan. So this was, you know, an N of 1. So the idea was to know her trajectory so we would know if it was different.
Right.
We were aware from going to the meetings with the PAX1 Foundation, we were aware that there was quite a range, and also we had a second patient that was referred to us who was, you know, quite a bit different in that she had attained more developmental milestones. So there's quite a bit of variability in the field. I mean, it would be nice to know across the spectrum of the field, and I did apply for a grant to do natural history on a group of patients with Olivia, but the NIH didn't see the value of that well enough to fund it, so it didn't get funded. But yes, I mean, collecting data for the general field would be good, but then you have to have a mechanism for doing that kind of study, and you know, the patients aren't all in one cluster together, so you'd have to fly them in and study them.
Did you?
And at the beginning,
I think flying is also not, you know.
Yeah.
It was,
It's hard to travel. But at the beginning, we thought we were doing an allele selective ASO, so we thought it would mainly be for Alya. It really wasn't until like the last year, 6 months to a year before she got treated that we knew we weren't doing that anymore. And now the ASO would be applicable to pretty much anyone with PAX1 because they all have the same mutation and it's the same gain of function mechanism.
Did you apply to the PAX1 Foundation for some funding for that study you were thinking about?
No, we applied to NIH.
No, I mean after the NIH.
Oh, no, I don't.
You should do that.
Well, we weren't, I mean, they were funding already a lot of basic science research, and so, no, we talked about resubmitting to NIH, but we never wound up doing that.
But I think the other thing is that, the kids do have very, very significant ranges of deficits. And so it's one of, when we were sort of going through the FDA process, one of the things, that's true is that Alya is at, probably the lowest end of the spectrum in terms of her abilities versus the other kids. So I think that individualized plan was so important for her because she looks so different than, many of the other kids.
So once you decide, okay, we're going to build this ASO, what's happening in your life? So this is going to mean, we talked earlier about the realities. This means you're going to have to go to Chicago more than once a year, even before the treatment starts, right?
Yeah.
All these things are going to impact your life. So just tell me what's going on with the family through this.
I think, when Liz agreed to take us on, we did, as a family, talk about it and make sure that this is something we'd be able to do, right? And I think Liz and her team are very good about sort of mapping out what the next few years would look like. Like, there was the baseline testing, which was sort of every 6 to 12 months, and building up to when the drug would be ready. And I think it was ready a little bit later than maybe we expected, so we have a little bit more baseline testing then. And then there's the drug itself, which is, it's not a one-time, dose. It gets administered at some point. It's probably every 12 weeks. And then there's the additional testing that goes with once the drug is administered to monitor, how the kid's doing. Yep. So as a family, we did think about it. We gave it a lot of serious thought, and we decided this is something we're going to be able to do. It's not for everybody, and Chicago to New York is probably one of the most frequent traveled routes. But it's still not easy to travel with a child that has a disability, and I think over the past 3 years we've figured out our schedules. we do the early morning flights. We know those won't be delayed. And I have another kid. I have a typical 14-year-old who also needs help at home. So I think I encourage people, to sort of, if you're going to travel to get this treatment, then make sure it's something you can do, because it's not fair to your treating physician, and it's not fair to n-Lorem to show up for 3 doses and then leave, because that's really not fair to anybody.
Yeah, so it's not that you can do this once, but you can do this repeatedly. You have to get a system down, a pattern down that you think works, which for you, I think we talked earlier, it's like you have to get up at something like 4 o'clock to be at the airport at 6, out of New York, out of LaGuardia, I guess.
Yeah.
Over to O'Hare, 3 times a year. And then you come right back the same day?
No, I mean, because of so that's the other thing is, it's not just a pill you take, right? Alya gets anesthesia and a spinal tap, so we usually stay overnight and then we fly back the next morning.
Yeah, that's a lot. Okay, so.
But it's better than waiting 6 hours at the airport because your flight's delayed. Yeah. So I decided that it was better to wake up at 4 a.m.
No, that's like a New Yorker trick. If you're flying out of LaGuardia, do it at 6 a.m. or you may never get out.
The same for O'Hare, actually.
Yeah. Yes.
Okay, so this is happening, and then tell me, so we know another couple things here. One is Alya's had, I think, 2 max doses. She just had her second max dose last week, I think.
So she had her first highest dose at the end of July, and then she had her second max dose at last week. And I mean, it's the max current dose, but obviously, if they can ask for changes if they're not seeing, significant improvement. But yes, it's still very early.
Right, so have we seen anything yet that you can, I mean, as we said before, we want hard facts here, hard metrics. Have you seen anything that you think, okay, yeah, maybe Liz can answer this.
Well, she had a slide on it before, that's why I'm turning it over to her.
Yeah.
Sorry.
Yeah, so we actually just she just got to 6 months, And the initial doses were low. She had 2 doses that were lower, and now she's at the top dose that the FDA is currently causing us to, cut the protocols off at. And so we just did 6-month repeat testing, and that's what I showed earlier this morning. It does look like her gain on the test was more than her gain on the test was over the time period before she came into the study. But again, it's 6 months, and we know there can be ups and downs in this test taking in our population. So we want to be careful about saying that we know that's a result. It'll be more of a result if we see it again at 12 months. And again, the more times we see it, the more solid it will be. But the person that administered the test could see that she was going higher than she had been before, and felt like, she was just doing better. And cognitive changes, like when a person has aggressive behavior and they get better, everyone in the family knows that, right? Cognitive change is a little more sneaky in that the patient is just getting a little more done, and then gradually you can kind of see, oh yeah, that's something different. And different diseases change at different rates. If the change is very gradual, it can be hard to see. If like you get the first infusion and suddenly they're doing something they didn't do before, then that's more obvious. But it's going to depend really on what gene we're working on as to what rate we can actually see the changes. So I think we're very positive. We know that we can go to, Alya hasn't really had any big side effects of the ASO, so her safety testing has been really good, and her labs have been really good, and so she does do a little bit of vomiting sometimes after anesthesia, but that's really an anesthesia effect and not so much a ASO effect. So we have the opportunity, we can go back to the FDA and ask them if we can go up to like an 80 milligram dose, which is what used to be in the protocols earlier. And even some of the protocols have had 100 milligram doses. So we can ask to go higher and see if we get a little more out of that while watching safety really closely.
So let's talk about the FDA too, right? So because she's a PAX1 pioneer, what did they require to have this trial put in place? And why is the cutoff? It's 80 right now?
It's 50 right now. As I understand it from n-Lorem, the reason, because our initial protocol actually goes up to 100.
Yeah.
But we switched neurology groups at the FDA, and the one we're in now is a little bit more conservative. So they're having you cut it they're not saying you can't go higher. They're saying we want you to go to 50 and then submit safety data, and then if it's safe, then we'll approve those protocols to go higher, kind of on a one-off basis, I guess. So the FDA, we have to submit, a whole IND. So I work predominantly on the protocol and some of the other pieces that have to go in with it, whereas n-Lorem provides all the chemistry information and the background and the preclinical testing for the drug, and then we submit that together all as a big package. And then the FDA has time to review it, and after we submitted the PAX1 protocol, we had to one of the questions we have to answer is how many people might have the condition. So we're submitting as an N of 1 protocol, but we actually know that there's many more patients who could be treated with this ASO at this point because it's not allele selective. So when they received that information, they put us on clinical hold because they wanted us to answer questions. First of all, the FDA has been a little challenging with developmental disorders sometimes because if it's a degenerative disease and the patient is progressing and has a threat of dying, then that's something they can see needs, an N of 1 treatment.
Right.
But we've had several times we've had feedback from the FDA about developmental disorders that these might not be serious enough to consider an N of 1 treatment. And then we always have to respond and try to convince them that yes, these are serious disorders and development is important. Like one of the things they've sent me is that we know that epilepsy is a serious disorder, but we're not sure that behavior and development are really a serious disorder. And then I have to send them back responses that are something like, well, if you have a child who can't ever communicate with you what's wrong with them and will be in diapers for their entire life, that seems like a serious problem. So we kind of have to work our way through the wording sometimes, and this time we actually got Taruna to help us us with that response to the FDA about why this is a serious enough disease to treat. So that was one of their issues. And the other issue was whether, is the fact that they know that there are many more patients with this, and whether they should require sort of more preclinical testing before allowing patients to get treated, knowing that this could expand into a large number of patients.
So like more preclinical work, and maybe was it suggested like an actual clinical trial? If we know that it's not allele specific and it could go to, I don't know, 200 people.
Yeah, they hinted a little in that direction, but the truth is that it is a very small, it's hard to run a clinical trial when you're an entire group of people that you can pull from, because you're always going to have to limit patients to make them more homogeneous. If you run a trial, you're not probably going to be able to get more than 30 or 40 patients in the country in a trial, and that would be doing really well. So that's, the statistics on that aren't really great. So so they wound up just noting that as something that they might require later, but we had Taruna write us a letter about the seizures and the problems.
Last year was a pretty tough year for us. I mean, Alya was having, she was having seizures pretty frequently. It was the first time I had used rescue meds a couple times. So, we certainly detailed that in the letter. And also, she really is very severe on the end of PAX1 patients. I mean, and I think that's documented by the way she started out her life with having, the status at 5 weeks and ESES and all those other things. And like I said, she has no board, she's not potty trained. There's very little she does versus, some of the other PAX1 kids. So she is a much more severe case of the disease. She has seizures. She had pretty, significant ones last year. So we documented all of that for them, and that helped.
Yeah, and we submitted it.
Yeah.
And then the FDA took the hold off and let it go forward. And we actually had submitted, there was the other patient that had been submitted to n-Lorem a way long time ago, who lives actually in Canada, was in that. We had created a protocol for both patients, even though they're functioning at a little bit different level in some domains. So what we made was a protocol that has kind of, if the patient is functioning at this level, then we're doing this set of tests. If the patient is functioning at that level, then we're doing this other set of tests. And so the protocol actually was written so that it could accommodate really anyone with PAX1, because we were kind of seeing the future and what would likely happen after people found out that we had an ASO that could treat anyone.
Yeah.
So they did pass it after that. But they kind of still had a warning that, if you want to treat a lot of people, we might think about making you have more preclinical data. And I'm not sure what exactly they're referring to with more preclinical data, but I think one of the steps that is traditionally done before clinical trials of ASO, but is not done with an n-Lorem ASO, is monkey testing. And I think they might be thinking that they want that. But honestly, I think we just have to keep working with them on, if we've already given the ASO to a certain number of humans, it's a bit of a step backwards to go give it to the monkeys.
Right, if you can
so
get
at this point, we really shouldn't need to do that.
Meaning if you have enough N of 1s out there that the human data is going to overpower the non-primate.
Yeah.
Right.
So we just added a third patient to the protocol, and it just passed 30 days on Friday. They have 30 days to respond to us and tell us that they...
Yeah, but is that part of the shutdown? No.
We don't know. So n-Lorem tells us they've had responses from FDA during this time, but we don't know if maybe they're only responding to the things that they feel are the biggest crisis, and that some things will go through just because they don't have as much staff. But honestly, 30 days is 30 days. There's been no official change in the policy, so we consider ourselves good to go because that's what the policy is.
And it's funny because the whole FDA thing, writing the letters and all this other stuff. And I remember Liz and the n-Lorem team sent me this text. It was like literally 8:52 a.m. It's like stuck in my head forever on a Tuesday morning, and I just dropped Alya at school. And they sent me this text or email, whatever it was, and it said, hey, we got the FDA approval. And I screenshot it and I sent it to my husband and I said, does this mean they have the FDA approval? And he was like, well, that's what it says, isn't it? But it was, it was that kind of thing. It was a monumental moment to hear that.
It's possible if Alya was not as severe, then they wouldn't have granted this as an N of 1.
I don't know. Yeah. It's hard to know. I mean, when they approved Alya, they also approved the other patient who isn't quite as severe, but who did have seizures at one time. She hasn't had them recently, so.
So this is interesting because, well, we have the PAX1 Foundation, but as more and more people in that community understand that there's an ASO, they may come forward and ask for treatment, and then the FDA may have to reevaluate all this.
Yeah, that is something that's already happening, so.
What does that mean?
Yeah, well, the patients are coming forward.
Yeah.
That's what's happening. What we don't know, so our plan is just to, as we get patients, and if they can come to Chicago, or, and if we screen them and it seems appropriate to treat them, we can add them to the protocol I think we just have to add them to the protocol one at a time, as has been done with other disorders, and find out, and just when does the FDA stop us? I mean, I don't think we need to ask the question. I think we just keep adding them to the protocol, send it back in. And if at some point they stop us, then we'll have to have a discussion about what's the path forward.
So you don't have to file a brand new IND for it?
No.
You just add them on?
Well, you could file a brand new IND if the patient was getting treated at another institution. They could have their own protocol. If they're treated with us, we've created a protocol now where we won't have to actually change the protocol pretty much for anybody. So we can just add them, and then it's just an amendment, and then they have 30 days to get back to us, and if they don't get back to us, then we can go ahead and it rolls on. So I think that's something we need to talk about as a field, is what if we want to just use the same protocol across multiple institutions? I think that should theoretically be possible without having to do a new IND, but maybe we do need a new IND. These are like the questions that are out there that we're kind of addressing with FDA. As we go forward, we'll find out what's required.
But so what's happening is, because you're on the IND, the patients are finding you, and they're coming to Rush and saying, we'd like to be added.
They're calling into our coordinators and coming to Rush and convincing us they can come to Rush, fly in from wherever they are as frequently as needed. So. Yeah.
Well, let's talk about that, because on the call we had before, you mentioned as well, it's like, well, okay, you can handle this, your institute can handle Alya, but if you get 15 coming in, and they're also saying, okay, n-Lorem's going to provide the drug, but who's going to provide the cost for administration? How is Rush going to be able to handle all that, or will Rush be able to handle all that?
Well, yeah, so I mean, we have some capacity. We actually have over 60 patients with Angelman syndrome right now on ASOs through one or the other of the trials. So in terms of infrastructure, we have that pretty built up. For the N of 1s, like I said before, we actually have a structure with Rush where we bill insurance for all the medical procedures, like blood work and anesthesia and LPs. If the patient's insurance, if we can't use the patient's insurance, which is true of our patient from Canada, obviously Canadian insurance doesn't come to the USA, then we get a lot of the stuff we need for the protocol in Canada and the Canadian insurance, and then they just come and we kind of minimize the billing so that they have a more financially doable cost. So for the most part, we expect that we would just continue to handle it that way. And then we have also created a structure that a foundation with philanthropy. We've created a foundation account called the N of 1, the N of 1 fund at Rush, which is something that philanthropy can present to donors who are just interested in supporting the hospital and want to do something novel like this. Sometimes it's not only N of 1. We have N of 1s with gene therapy, not just n-Lorem, but like sometimes there's a family member that knows that the patient is getting treated at Rush, and they die and they want to leave money to somewhere, and so this is a fund that could be used for anything. There could be we don't ask for donations from families, but there could be donations from families that are involved with this, or from people that know patients that are getting treated at Rush, or it could just be general Rush donors. And so we put the funds in that account, and that's what funds our coordinator and some of the drug preparation things that we need to do. Like we need to make the infusion, and that's a pharmacy cost, and we can't bill that to insurance. So we've kind of divided it all up, and are doing.
I think does that make you nervous at all? Because I don't know. Can you count on constantly people being open-hearted enough to contribute in this way? That's the whole thing.
Yeah, we're also working on some major philanthropy, so we're hoping that we can keep what we're doing going.
Yeah.
Through a combination of philanthropy and grants and industry-funded trials that may fund a coordinator, but then the coordinator does some work as on another project as well. So there's a variety of different ways to use, or money that we have left over after a clinical trial. I mean, you just have to kind of be creative. And I think one thing that Rush has let me do that not all institutions allow is that if I have money left over after a trial, I can use that to like start the next trial, because you always get the money at the end of a clinical trial from industry. You're not as much, you have to do startup kind of on your own. And so I can roll that money over, and then we can use that money. Some institutions, they take that money away from the investigator, whereas we've been able to create an account that we put our money and the institution doesn't try to take it.
Yeah.
So
well, I think the other thing you talked about before also was your ability for them to, because I see the bills from insurance. I mean, they really do bill insurance, and it works, like if you have the right insurance. So that's also something they've learned to do that, you know, maybe other people could benefit from knowing to do.
It helps. We check out the insurance ahead of time. We make sure they're in plan. You know, we work with the insurance, and so.
But you said the right insurance. Is there like certain insurers that are more amenable to this?
Mine is right.
Hers is good.
You know that. Yeah.
The big problem we have with insurance is when the patient has Medicaid from another state, because Russia's now really clamped down on that. They don't want us to see patients with Medicaid from out of state. But we do believe that all patients deserve treatment, so we're currently trying to work on policies with Russia about how to work around that for orphan diseases.
Yeah.
So anyway, I think to some extent we can take more patients. There will be a point where we can't, you know, where it's just too much for us and where people are flying over to us from all over the place. And this is what happened with our expanded access program for Niemann-Pick type C. And that's when we started to pull in hospitals from elsewhere. And I run the EAP, but there's a PI at each site, and they use the same protocol and then treat the patients. And I envision something like that could be done with a single protocol for N-of-1 studies, which would then, you know, if we're all using the same protocol, that allows us to add the data together and to do more kinds of multiple N-of-1 analyses. So I envision something like that for N-of-1s. I don't know what it will take exactly to structure that with FDA and so forth.
Yeah. We're getting down to the end of this. Any questions? I've got a few more, but any questions from the audience for these two? If so, there's a microphone there and one over there. Okay, here we go.
Quick question. Dr. Kravis, why is it that certain hospitals, like why is Rush able to bill for insurance, or why are other institutions not able? Is it a state-by-state thing, or is it just the institution, or like why can't some bill?
It's just the institution's decision. I mean, the institutions are, in general, some institutions feel that if it's an investigational drug, you shouldn't bill insurance. Well, I mean, cancer bills insurance for all kinds of protocols. We're not billing for the drug. We're billing for, as was pointed out earlier, we're billing for the treatment associated with the drug, which is basically what a lot of the cancer protocols do. And so it's really just a decision of the institution. They're also worried that the insurance won't pay, because the insurance will know it's an investigational drug, and they say they won't pay for anything. But again, we've run these by insurance, and it's actually been kind of, so far the insurances we've worked with, it's been kind of easier to get the insurance on board than to get the institution on board. But this was a decision Rush made after I had a Zoom call with like all the financial people from all different levels and explained to them what this was and why it was not possible for an institution to fund these treatments forever, because a patient, if they work, the patient might be on them for life, and that the diseases are so rare that the drugs will never be approved, although, you know, Stan may have a path. He was talking about that. But some of them will probably never be approved. And so we just had a nice talk, and eventually Rush decided that this was okay, and that they would treat this basically like we treat compassionate use or expanded access, which is, there's an official, you know, FDA policy that you can bill insurance for expanded access. So, but other institutions have looked at it differently.
Yes.
Good afternoon. My name is Natasha Hendricks, and I'm from Portland, Oregon, and I have a daughter with PEX1. And I just wanted to say thank you to Taruna for creating the foundation, because we got diagnosed in 2021 and immediately found the community. And this is how I found out about n-Lorem. And now I'm here, hopeful. thank you for being a pioneer. Because of you, we have hope.
I mean, I think I just want to end the panel on that, actually. Yeah, if there are no more questions, that's, we're done with this one. Thank you, the two of you, it was really nice.
Thank you. Thank you.